So welcome all again to this webinar. We're really excited to host an excellent lineup of speakers on the topic of future remnant liver analysis. First off, Roel Bennink will speak. Roel is a nuclear medicine physician and a professor working at the Academic Medical Center of Amsterdam. Roel is an author on many papers on the topic of liver function assessment prior to surgery, and he helped Hermes to specify our liver remnant software as well. So yeah, take it away, Roel.
Okay, thank you for this nice introduction. You'll see my presentation now. Yes, I will talk to you on the clinical needs and development of hepatobiliary scintigraphy for future remnant liver analysis. And I show you first a nice editorial which appeared in 2016 in HPB, describing that hepatobiliary scintigraphy is at this current stage a major step forward toward safer liver surgery. And at the end of this presentation, I hope that I will convince you that we really should go this way. But let's start with an example of a patient. This is a patient, a male patient with colorectal liver metastases, as you can see on the left panel. This is an FDG PET-CT where you see two large metastases on the left side before and on the right side after neoadjuvant chemotherapy. And the next step for this patient would be resection. And as you can see, to resect these two metastases, this patient requires an extended right hemihepatectomy. And the question is, at this time point, can this patient undergo this resection without elevated chance of morbidity or mortality? In general, we base the criteria for resection on volumes, and the established method was about 25 to 30% of future remnant liver volume. There are patients who, there are people who exclude tumor volume or who correct for body surface area. But this is for patients with otherwise normal liver or liver function. But if there is the possibility of liver dysfunction, 40% of liver remnant is generally advised. But the problem is that in most patients, we are not aware of the quality of the liver tissue, or if there is a hepatic comorbidity, this can be distributed inhomogeneously in the liver. Now, the idea was to get an idea on liver function based on hepatobiliary scintigraphy. And the agents we use for HBS, or as we call it now, Hebis, because this is a little bit more easy to pronounce, are the immunodiacetic acids, and the most known of these family is mebrofenin. The immunodiacetic acids are lidocaine analogs, and as you can see, when you put two lidocaines opposed to each other, you can nicely catch technetium in the middle and you get a radiopharmaceutical. And these agents are taken up by the hepatocytes quite similarly to bilirubin, or also ICG. And ICG is indocyanine green, which is a dye which surgeons already use for a long time to get an idea about liver function, because this dye is taken up exclusively by hepatocytes, as in fact is also bilirubin and also mebrofenin. So we have a nice agent to look at function of hepatocytes. And this is only one slide on the technology, because this will be discussed later on in this symposium. If you inject mebrofenin and you make a fast dynamic scintigraphy, we perform 38 frames of 10 seconds. You can nicely see that mebrofenin is taken up fast by the liver, and after 5 to 6 minutes, all radiopharmaceutical is taken up by the liver. And the Ekman protocol, which we currently use for the determination of liver function, is basically calculating the uptake rate of midbrofin in the liver, correcting for blood pool, because the liver is a very well perfused organ. So you should look at the specific uptake rate in a certain time frame, which is past the first pass phase, but before there is excretion of the midbrofin into the bile. The first question was, if you do a prediction of future remnant liver, does this prediction correlate with immediate post-operative outcome? And this, in fact, was the first step we undertook back in 2004. We published this in the Journal of Nuclear Medicine, where we compared the estimation of the future remnant with 1 day post-operative effective remnant liver function, both for patients with right hepatectomy, but also patients with left hepatectomy. And you see that this correlation is very good. So predicting future remnant liver function is something which we can really do. Next question, of course, is how much future remnant liver function do you need for survival of your patient, or for trying to circumvent immediate post-operative morbidity. For this, we looked at 55 patients with different types of hepatectomies, and looked at outcome of these patients. And if we look in this group and display the data, we came up with a value of 2.69, which we use now for 2.7% per minute per square meter of future remnant liver function as a threshold for safe resection. And if you use this threshold of 2.7, we see that we can predict with high sensitivity and specificity, and most importantly, with a high negative predictive value of 98% outcome of these patients. Interestingly, also to see is that when patients have a healthy liver, volume and function correlate very well. But if patients have hepatic comorbidity, this correlation is far less. And as I explained some slides ago, in most patients, we are not sure of the quality of the liver. The next problem we face is that our technology is based on dynamic scintigraphy, and this is two-dimensional imaging, where liver segments not always follow the nice perpendicular contours which we would like to have on dynamic imaging. For instance, this will work easily if you consider segments 2 and 3 of the liver as your future remnant. As you can see on transverse slices, that the boundaries between segments 2, 3, and 4 are perpendicular to the body surface of the patient, so you can nicely draw regions of interests. It becomes more difficult if your future remnant liver is segments 2, 3, and 4, where the delineations between segments 4 and 5 to 8 are not perpendicular to the body surface. So where to put the boundary of your region of interest is difficult. So therefore, actually, you would need to do a SPECT. And because this agent is very well taken up into the liver, you can do a SPECT quite fast on the maximum of the hepatogram. So you make a SPECT in about 5 minutes before there is excretion of the activity into the bile, followed by your CT. And you can do a late excretion phase if you want to. And this can be interesting in patients with, for instance, biliary tumors where obstruction might occur. And after doing SPECT, you get three-dimensional data where you can do a lot of visualization or processing and calculations, and you can do the hepatectomy before the actual surgery and make an estimation of future remnant liver function. Now we go back to our patients and we go processing this data. And here you see an example of processing, how we do it currently with the Hermes software. And for our patient, this patient had to undergo an extended hepatectomy of the right side. So the future remnant liver would be segments 2 and 3. And calculating the future remnant liver function of this patient with his colorectal liver metastases would come out with 1.5% per minute per square meter, which is below the threshold of 2.7. So this patient would not be an ideal surgical candidate at this time point. So what was done in this patient was that he got a portal vein embolization of the right side. You see this portogram before and after the embolization, and a few weeks later, you can look at the function of this patient again. You can see that this patient has hypertrophy of the left liver segments, but more important, you see also increase in function on the left side. And once again, you can calculate the function of these liver segments. And in this case, the liver function increased from 1.5 to about 3% per minute per square meter. And this region, of course, is drawn on a two-dimensional image, but it was assessed on SPECT CT. So these values actually correspond to the future remnant liver function of the patients. So with portal vein embolization, his function increased significantly, and at this time point, the patient is eligible for operation. Introducing this technology into our patient group resulted in a dramatic reduction of postoperative liver failure and a reduction of mortality due to liver failure from about 9% to 2% liver failure and 8% to 1% mortality. So this is quite interesting when you are doing major liver surgery. So the take-home messages for my part of this symposium is that Hebis is actually a major step towards safer liver surgery. Most importantly, because we can better select our patients for liver surgery. If patients do not meet the requirements for safe resection, we can select them for pre-treatment options. And we see an actual reduction in postoperative mortality and morbidity, and a very important also reduction in cost, because patients stay much shorter on ICs and high care environments. So introducing this is really something which is very interesting for hospitals who are into major liver surgery. Thank you.
Thank you so much, Roel. That was a really great introduction, and that's a pretty astonishing outcome that you reduce mortality from 8% to 1% after introducing this processing before the surgery. Wow. If anybody has any questions for Roel, please type them into the questions section or the chat section, if you can see that. And we will come to them at the end. There'll be a Q&A section right at the end. But please, if you have questions as you're going along, if you think of questions and you want to type them so you don't forget, just type them down into that questions panel or the chat, and we will get to them later. So next, I would like to introduce Michael Wilson. Michael is a nuclear medicine physicist working at the Queen Elizabeth Hospital in Birmingham, and he will talk to us about supporting the clinical service in nuclear medicine for these patients. So Michael, take it away.
Thanks very much, Helena. Yeah, so as Helena has explained, I'm a clinical scientist, a physicist working in nuclear medicine, and Bobby, who will talk to us shortly, came to me a couple of years ago, maybe a little longer ago than that, and asked whether we could implement the work that Roel was doing. And so my job here is to give you something of a technical interlude as to how we actually do the quantification of liver function that Roel talked about. So my talk is really in two parts. One is, how do we measure the global function of the liver in absolute terms? As Roel says, we want to say what percentage of this tracer is the liver taking up per minute per square meter, and also how we carve the liver up spatially and decide how much of that function belongs to the future liver remnant or FLR. So I'm going to talk about how that quantification is achieved, and the test is actually quite quick, as I think that Roel has explained. There's a very fast dynamic study. We use a high-res collimator, and we inject the technetium labeled Tibida. We use about 150 MBQ. Other centres may use a little bit more.
Sorry to interrupt you, Michael. Are you sharing your presentation?
I am.
I'm not seeing it. Is anybody else?
Okay, right. Well, let me.
Sorry, let's try again.
Yeah.
Adeline, if you take the presenter back and then, oh, that looks better.
Okay. How are we doing now?
Yes, perfect.
Okay, apologies.
Thank
no,
you.
I don't know what happened. Yeah, so the first part of the first part of the test is this fairly rapid dynamic study, and it's a conventional sort of liver uptake study. We acquire anterior and posterior images for reasons that I shall come to in a moment. Then, as Roel said, we do a very quick SPECT, just about 10 minutes in our case, and then we do a CT. And just going back to the SPECT, it's important that when you're doing a fairly swift SPECT like this, you recognize that the camera will actually spend some time moving between projection points. So if we've got 60 projection points here, and it takes 3 or 4 seconds to move between each of them, then that is 3 or 4 minutes where you won't be acquiring anything, and that's wasted time. So it's important that you either switch on a continuous acquisition mode or an acquire during step mode. So in practice, we're acquiring 6 seconds per step and the 4 seconds that it will take the camera to move to the next step. Otherwise, our study will not be quick enough. The CT part that comes immediately after the SPECT, that's entirely up to you. We're going to use it for attenuation correction and delineation of the liver, but otherwise the quality of that image is entirely up to you. So let's deal with the dynamic part first, because that's going to do most of the heavy lifting in terms of the estimation of liver function. And so it's important that we include in our image the heart and the liver in their entirety, and that we do ant and posterior images, because what we intend to do is to remove the effects of attenuation, obviously tissue at different depths, and we do that as a standard technique. We essentially flip the posterior image, we multiply the two images together, we take the square root, we now have a geometric mean image, and this removes substantially the dependence of the count rate upon the depth of any tissue. So attenuation effects are uniform. It's as if the whole of the functioning tissue of the body was about halfway through the body. So we then want to process the curves from this geometric mean image. So we will draw a region around our liver, we will draw a region around our vascular input. We typically choose the sort of left side of the heart, and we'll also draw a region around the entirety of the image. And we plot those over the first 6 minutes. And from these, we're going to estimate the liver function. Now, first of all, there's a fairly cheeky shortcut here, which you probably will never use, and we rarely use it. But actually, if we ignore the liver and the total activity curves in the field of view and just focus in on the vascular activity, then after the initial blip, and once the tracer has equilibrated throughout the blood pool, then we can fit a single exponential, and this is the only piece of mathematics that I will include. The exponential has this form, and so we fitted the intercept B0 and this number here, K, and K is just the fraction of the tracer that is removed per unit time, and we've measured our time in minutes, so we are saying that the body is removing this tracer at 15% per minute. And since, as Roel said, it's basically only the liver that does this, then we could deduce from this that the liver is extracting about 15% per minute, and that works surprisingly well. It's usually a slight overestimate because it appears that the liver is not the only organ doing this job, but it is substantially the only thing that's doing this job. However, that's not the technique that we use. Instead, if you're familiar with renography, you might be tempted to take a point at which the blood has equilibrated and look at that point on your liver uptake and say, at what rate is the liver extracting tracer from the vascular input? And you can do that. So in this particular situation, we would get a certain amount, delta L, I'll call it, removed in 1 minute, but we've no idea what that is in any absolute term, except that the total counts in our image are likely to be about all of the counts there are in the body, particularly since the liver is going to grab hold of this stuff pretty damn quickly. So there is our 100%. So we can compare delta L with that 100%, and we find typically that you're going to get a number which underestimates liver function. And that's simply because this vascular blip that occurred at the beginning chews up, well, the liver chews up a huge proportion of the tracer, and therefore there's not as much left as we otherwise surmise. So this actually, although it would work well for renography where we're comparing relative function, doesn't work for absolute function. So what do we do instead? Well, there's a tried and tested method for dealing with problems like this where the input to your in this case tissue, which is the liver, is varying with time, and the technique runs something like this. Apologies to those of you that are familiar with this technique. I'm not going to use its name, I'm just going to describe it to you. So basically we say, look, up to a certain period of time, this blood pool delivers a chunk of tracer. We will measure the area under the vascular curve as a measure of how much tracer has been delivered, and the response is that the liver has held on to this much tracer. Part of that is because it's just a big wash of blood has perfused into this liver, and part of this is because the hepatocytes have started to pull this tracer out of the liver. Now, the trick we use next is to say we wait a period of time until the same amount of tracer has been delivered. So the area under this second segment of the vascular curve is equal to the first. And again, the liver uptake will have increased, and we say, look, it's as if, even though we know more time has gone by than that first segment took, it's as if a similar amount of time has passed by. This is some kind of pseudo time, if you like, and we say, had that first segment of time been, say, 1 minute, then in the second minute we would have had this much, had the flow of tracer been uniform. And we can continue that trick, so we say how much time has gone by until we've had a similar amount of tracer flow under the bridge, as it were. How much is accumulated? Well, that belongs as if in our pseudo time it happened just, in this case, let's say 3 minutes later, and so on. And so we end up with a time normalized curve which delivers the tracer to our liver at a steady rate, and therefore we can read off the change in 1 minute, and that is our absolute liver function. So that's broadly the technique that we use. There are different ways to skin that cat, but I've tried to illustrate it in a way that's sort of pictorially helpful without using any mathematics. So now we've done most of the heavy work, we need to move on to the second part, which is to estimate the fraction of the liver that we're going to take away and the fraction that we're going to leave, and apportion this function to those two pieces. So we are 6 minutes into our study, and as Roel said, we're now going to do a spec study. That seems like a very clever thing to do because the uptake in the liver is changing quite rapidly, but as Roel explained, actually it peaks, and so the variation is really relatively modest. And so if we get in there quick, we can do a SPECT and hope to see a quasi-static picture of the liver distribution. So as I explained earlier, we use either a continuous orbit or a acquired during step, and we then have to be fairly careful about how we reconstruct our spec study, because we want this to be a quantitative picture of uptake. So we need to do attenuation correction. We'll use the CT for that. We need to do scatter correction, and we use Hermes Monte Carlo based scatter correction for that. And whilst you're at it, you might as well do resolution recovery. And again, we use Hermes to do that for us, and we get the three-dimensional distribution. So we'll come back to that spec stuff, and we do the CT. The next job is just to outline the liver. So this is relatively straightforward, although it's just very tedious. We identify the liver outline by hand at strategically placed intervals along the z-axis. As I say, this is all done by hand. In practice, it will take about 5 minutes once you've got the hang of this kind of thing. And we work all the way through, and eventually we have a three-dimensional set of slices through the liver, which we can then ask Hermes to interpolate for us, so that we've got an entire volume of interest, which we can then just display as the volume of the liver in this particular case. So all we need to do now is to divide this into two pieces. And this is where we get the clinician involved. So in our case, Bobby comes along, he's going to do the surgery, and he decides that he's going to put a resection line at this point, and then he will advance a few slices, and I'm going a little bit further than perhaps he would, and then I'm going to resect at this point. So we have another contour that we can build up in 3 dimensions and split the liver into these two volumes. So the resected volume, which I've shown in green, and the future liver remnant, which I've shown in red. Sorry, let's just go back to that. So we've divided the liver into those two pieces, and now it's simply a question of measuring the amount of activity that's in these two pieces. So you can see on the CT image, we've got the whole liver has a volume of nearly 2 litres. And we've divided it into two pieces. The piece that we're going to keep, the future liver remnant, has a volume of about 45%. And then if we look at the SPECT part of the image, here we're interested in not so much the volumes, but the counts that are in those two portions. And the portion that we're going to keep, the future liver remnant, has about 53% of the function. So a significantly larger chunk of the function belongs to this smaller chunk of liver by volume. We've already figured out that the total function is 15% per minute. So the future liver remnant is just 53% of that. So we multiply the two, and then we need to figure out what is the surface area of our patient. In this particular case, the patient was quite large and had a 2.2 square meter surface area. So we divide by that. And in this particular patient, we've got 3.61% per minute per square meter, and as Roel indicated, that's above his threshold of 2.7%, I think it was. So that's my lightning tour of the sort of heavy lifting as far as doing the quantification is concerned.
That's great. Thank you so much, Michael. That was truly beautiful. I don't think I've ever seen a presentation as beautiful as that. If you have any questions for Michael, please type them into the questions panel, and we'll get to them at the end. Next, we move on to Bobby Dasari. Bobby is a consultant hepatobiliary and liver transplant surgeon, also from Queen Elizabeth Hospital in Birmingham. Bobby will share his experiences with this procedure and the importance of surgical planning, as well as a look towards the future of future liver remnant analysis. Okay, Bobby, over to you.
Thanks, Helen. Thanks for that introduction, and thanks for giving us this platform to share our experience. It is somewhat an honor to share this with. Can you see my slides, first of all?
Yeah, we can see the PowerPoint. If you, yeah, that's it. Perfect.
Yeah.
Great.
It's in fact an honor to share this platform with Roel Bennink, whom we actually learned this technique from, and we implemented at Queen Elizabeth along with my good colleague Mike Wilson. I will try to talk more about the clinical applications of Hermes and why it is useful more in liver resection surgery than in transplantation surgery. So the regenerative potential of the liver has been well recognized and documented even in the mythology, where Prometheus was tied to the rocks and the eagle was eating his liver, and it would regenerate overnight for the eagle to come back and eat it. So that regenerative potential is exploited by the liver surgeons for the patients who would benefit from liver resection. In the process, over the past 2-3 decades, in the initial years where the liver resectional surgery was being developed, there was a fair extensive resections being performed, and the mortality, morbidity used to be higher, and not anymore though. When the initial reports were coming up, the liver failure was one of the major complications that was leading to the mortality. And it was reported in various terms clinically, whether there is hyperbilirubinemia, jaundice, ascites, until we had this ISGLF definition of PHLF, post-hepatectomy liver failure, which is an assessment of the bilirubin and INR levels on day 5. So it is well accepted and standardized over the past almost a decade now. And if you look at the rates of PHLF, it would vary anywhere from 15 to 30% in the literature. When we looked at our large cohort of about 1,200 patients, we are one of the largest resection and transplant centers in UK as well as maybe in the Europe as well. So when we looked at our 1,200 patients, we had a PHLF rates of about 20%. Of which grade B and C were about 10%. Overall, there is an impact on the hospital stay, which was longer in those who had PHLF, as well as a 90-day mortality, which was higher in those with grade B and C PHLF. We did come up with a risk score based on our data, which essentially boils down to how the liver is functioning and how much of the liver that we're going to resect. And the higher the risk score, the higher the risk of PHLF. There are several other factors that could influence PHLF. If the patient related, if they have diabetes, obesity, that could cause NASH, non-alcoholic steatohepatitis. Or then if colorectal mets who go for chemotherapy, they can have chemo-associated hepatitis, various hepatitis kind of infections, viral hepatitis, of course, cirrhotics with HCC. Even the elderly patients who have, even though they have the same volumes, it doesn't always translate to the same function, especially if you're doing a major liver resection. Of these surgery-related factors would be these, where the blood loss and the amount of liver that is being resected. So the liver volume, what we are going to leave the patient with, is very important, and it is well accepted. And the minimum safe volumes are 25% in patients with healthy liver and 40% in those with background liver disease. And it should be standardized with the patient's body surface area and weight. And in the West, we follow Professor Wathe's standardization principle. In the Eastern population, it's a different formula, but essentially it should be standardized. However, this volumes of the whole liver may not always, and that of the right and left liver may not always represent the actual functioning liver volume, especially if there are multiple liver tumors, large liver tumors, or if there is compression of the portal vein or bile ducts, which is causing atrophy. And also a cohort of patients who are more and more coming up and going through two-stage liver sections if they don't have adequate volume. And that's why the functional assessment is very important. And the gold standard in functional assessment is ICG, has been ICG, essentially very much extensively investigated by Japanese, in the Japanese literature, and they have ICG-based algorithms based on which they do undertake more major resections. But the difference between ICG and the scintigraphy is that you cannot get the differential function. The function in the remnant liver, you cannot assess it adequately. It just gives you the global function. So one of my senior colleagues, John Isaac, has encouraged us to start looking into it about 3-4 years ago, as Mike mentioned. And when I approached our department of nuclear medicine, which is filled with enthusiasm that is quietly seen in this department, and a very reliable group of colleagues there. So when we discussed initially, they were very welcoming, and Mike and his colleagues who have started exploring the options, and we started implementing it. So the first and foremost thing that is striking from using the Hermes software is this is giving me the volume of the liver as well as the functional percentage. So why I should not use this software rather than a simple CT volumetry? I didn't have an answer. So with the Hermes, you are getting, you're able to assess not only the sum percentage, which is, sorry, the volume percentage, but also the sum percentage. So that's the starting point. You're getting the anatomical volumes as well as functional volumes from here. And then we wanted to make sure the volumes that we're measuring are accurate, or at least comparable with the existing software tools. So a couple of the junior colleagues have looked into about 140 patients who had right and left hepatectomies in a retrospective manner. It's a caveat of the fixed specimen. And they retrospectively did the volumetry on a couple of softwares, which is one of which is Hermes, and the weight of the resected specimen from the volume correlated well with the volume assessed on the Hermes. And also the PHLF rates were predictive enough with a ROC of 0.76 for the Hermes. And we also wanted to make sure we have reviewed the literature enough before implementing it. And one of the medical students has done a pooled analysis of all the literature that is published on the values, cutoff values. And it makes sense that if you reduce the bar, the higher the predictability of PHLF. And as 2.7, we accepted 2.7 as a measure of determining the safe resection of the FRLF functional uptake in the remnant liver. And then we looked at our first 100 patients who had the functional scans, and I think this is the most striking thing I have learned from this. So there is about 20 to 40% of the patients who have discordance between their anatomical volume and the functional volume. So you do a CT volumetry, or you do standardized volumetry based on the anatomical volumes, and you compare that with the functional volume percentage that is based on the SPECT CT that is demonstrated by Mike and Roel. There is a significant percentage of patients who had more than 10% of discordance. That is important, and that is clinically very important, because these patients, if they're estimated as at the standard risk of liver failure, we would be wrong. And the other group that is coming up is those who are going for the two-stage resections, portal vein embolization. So if you see this patient who has got, first of all, a background liver disease with a hypertrophied caudate, pre-cirrhotic patient with a intrahepatic cholangiocarcinoma, you could see better on this cards. They had a functional assessment. Sorry, yeah. They had a functional assessment, and the anatomical percentage was 32, and the functional percentage was 28, and the FRLF was 1.1% per minute per meter square, which is very low, and they're at a risk of liver failure. So if you move on to the patient, the same patient who had portal vein or dual vein embolization here, and had the assessment done again, you see the anatomical percentage of 45%, and the function is about 55%. So the difference between the anatomical volumes with the intervention is 13%, whereas the functional volume is about 27%. Again, this is very important for me as a surgeon to put this high-risk patient with pre-cirrhotic liver going for a major resection or after dual vein embolization. So based on that 27%, the FRLF is 4.26, and it would be safe for this patient to go for a resection now. Similarly, the two other patients I just want to show with a difference of 11% in the anatomical volumes before and after venous embolization, whereas the functional volumes were 24%. And for this patient, the difference was 17 and 32%. So there's almost a 50% difference in the anatomical hypertrophy as well as the functional change. Now, this is very important because if a patient doesn't have enough anatomical volume after this procedure, we would be saying that they won't be good for going for the surgery, whereas which would be a disadvantage if they have enough function on that side, and you would expect there to be good function because there is an atrophy on this side already. So this is a very important cohort of patients. We should consider scintigraphy as pretty much a standard. Now on the liver transplant side, not a routinely done procedure, but an auxiliary transplant, liver transplant patient who was operated in 2018 but by one of my senior colleagues, Paulo Moisen, who is now moved back to Italy. I was involved with this case and followed this young girl who had paracetamol overdose and needed liver transplantation. So in auxiliary liver transplant, what we do is we keep the recipient's liver, left lateral segment, and we give the donors part of the donor liver over here on the right side. So the idea is over a period of time, this left lateral segment should grow and this would atrophy. And you would help that to happen by reducing the immunosuppression they are taking. And how do you reduce the immunosuppression? How do you know that there is enough function in this liver to be bold enough to reduce their medications? So here for this girl, scintigraphy has been very helpful. So the initial scintigraphy that she had in May, the function was only 20%. And the uptake, the FRLF in Jan 2020 was 2.91. And this is when we felt confident. We started reducing the immunotherapy, immunosuppression she's on, and the follow-up scan, which we were hoping to do in 6 months. But with the COVID pandemic, we had to leave it a bit longer, which was probably not a bad option for her. So if you see here, the function has grown to 3.57, although the anatomical function has not, the anatomical volumes and the fractional function itself has not increased. But come Jan 2022, you can see that this left lateral lobe has significantly hypertrophied with an atrophy of the right lobe. And that's because we have reduced the immunotherapy from here on, and she's almost on nothing since Feb 2021, and now she won't be on anything from Jan 22 because she doesn't have any donor graft anymore. So that's a very interesting case, not a routinely done procedure, but where it is done, it is very useful have scintigraphy. So those are my slides. My take-home message is there is a definite role for scintigraphy, and it is essential to establish what's the difference between the anatomical and the functional distribution, especially in the high-risk patients, who would be those with primary liver cancers, which are HCC, cholangiocarcinomas, or patients who have a lot of chemotherapy for the colorectal liver disease, of those who are going for the two-stage procedures. Are there any limitations? I think we're very fortunate to have support from our nuclear medicine team, but speaking to colleagues from other units in UK, I think it is having that manpower, resources, and also developing that confidence that they can deliver the surface has been a limitation, and webinars like this should help. And further research potential, I think there are I wouldn't say competitors. There are other modalities such as MR functional assessment that are coming into use, and we should be comparing the scintigraphy with things like MR, and also we should be assessing the kinetic growth rates with for the two-stage procedures, and we should we should be able to do some mechanistic research as well as we move forward. Thank you.
Thank you so much, Bobby. That was such a nice good news story that you shared at the end there. And also it's so great to have you here. I think collaboration with surgery and nuclear medicine is really beneficial, because now there are so many procedures that we do in nuclear medicine that are purely for surgical planning. And not only this, but lung lobar quantitation, parathyroid localization, sentinel nodes, and there's loads. And it's great to have a surgeon engaged with us and with nuclear medicine. Okay, so what we're going to do now is I am going to, so if you have questions for Bobby, please type them into the questions panel, and we will get to that shortly. Now I am going to demonstrate the dedicated Hermes workflow for doing this processing. So I'm not seeing the screen share thing. Let's just, oh, hang on, maybe I can do it here. Is anyone seeing my screen yet?
We do.
Okay, great. You're seeing Liver Remnant?
Yes.
Yes.
I do.
Great, just checking.
Confirm.
Okay, so this is a dedicated Hermes application that we've made to be able to process these sorts of scans. So as you've already heard, we've got a dynamic to start with. So this is 6 minutes of dynamic injection, capturing the heart's input there, and then you can see it very quickly localizing to the liver. Actually, so that geometric mean that Michael Sanasi described in his presentation has already happened. So we've got an anterior and posterior image dynamically that have been acquired. The application has made a geometric mean dynamic from those two on input, and it's showing them to you here. Then we also have a SPECT CT, which is taken immediately after the dynamic has finished. So working through the processing. Let's do some regions. So we have a region list ready for you here. So blood pool is the first thing to draw. Just going to draw it over this heart input region there. Now it skips on to the next region, that's the liver. So I'm going to use our nice seed tool to just get the liver outline there. And the remnant liver, we can just do, so it's just a rough guide for a minute on the planar. We're going to refine it on the SPECT. But just to give us a quick idea at the start, let's just assume that we're going to do an easy kind of basic split like that. Okay, let's hide this for now. We have some results, but we first of all need to enter the weight and the height, because some of these results are expressed per body surface area, and we calculate that from the patient weight and height. So if that's available in the DICOM header, if you've typed that in on the scanner, that will be brought through, but if not, you can just add it here. So let's add some values here. Apply that, and okay. So we have some initial values to start with. Now, as already described, let me just try and find some notes. So we're looking at the liver uptake rate, which is that's this one here. that is the amount of tracer taken up in the liver per minute as a percentage of the total activity in the field of view. The next one normalizes that to the body surface area, so you get this per meter squared unit. And then this future remnant liver uptake just takes the ratio that was from these regions, and from the counts there, it just creates a ratio on that and expresses the future portion of it as a percentage of the total liver uptake rate. That is then normalized to body surface area for this value. Now this one, high clearance at 15 minutes. So what we've got here is something very similar to what Michael showed, is that we have this, the solid green is the blood curve coming in from this region, and then we fit this, this exponential to it there. That is then, so you can, as you can see, it equalizes quite quickly there. Then we extrapolate that out. So we've got 6 minutes of data, extrapolate that out to 15 minutes and express it here as the clearance in this value. So that's the planar portion, which, as described, if you're doing quite a simple split, which has a quite nice ant post kind of alignment, maybe that's sufficient. But actually for more complicated ones, you might need to do something based on the 3D images, which is why we have the spec CT as well. So let's go ahead now and process that. So Michael showed a very detailed anatomical based processing. What I'm going to do is easier and perhaps not so accurate, but it's quicker for a demonstration anyway. We can use the nuclear medicine counts to draw these the liver regions. So first of all, I'm going to make a constraint. So I'm going to look on this view and I'm going to say that this portion is going to be my future portion. I can do that on multiple views, so I can do it down here as well. Yeah, just that bit there. Okay, so that's drawn those two. The liver volume, I'm going to use an absolute threshold on that, on the nuclear medicine. So I double click and the application then draws a threshold based on the counts of the nuclear medicine to include all that. I can do the same for the remnant liver, this time starting off the click inside the constraint. That region is then constrained by both the transverse constraint here and the I draw on the coronal image here. If this isn't quite right, it's possible to make an edit here as well. So maybe I want to just do a right click and edit. You can just sort of bring it out there to change it if you wish. Now the last thing to do is that now you can see a really hot biliary tree and gallbladder in the image. Now this of course would distort our results because this is not representing true liver functional uptake, it's representing the drainage part of it. So we need to mask that out. And we have a really nice way of doing that. We have this masking volume preset, which is going to take this mean liver value. So for this patient, 5,109.2, and it's going to set that as a mask value in this masking volume. I'm going to use the relative to max option here. So let's make a double click inside, and then the application will automatically find all that very hot biliary structure and just mask it out so that it matches the liver mean now. So that's it. That's the processing done. So now the extra results that we have here are the future liver uptake, but this time taken from the count ratio of the SPECT rather than the count ratio on the planars, which, as described before, is necessary if you're doing something that's coming more into the liver kind of this way rather than just a more easy and post style separation. Okay, so that's the Hermes application. Now we will start on the questions. So I think my screen share stopped automatically there. Thank you. Let's go. So if all of the panelists could please put their webcams back on again, and I will read down the questions from the start. So this is from Dirk Helwig. I apologize at start for all name pronunciations. Dirk asks, are there threshold values for radiopharmaceuticals other than mebrofenin for the prediction of sufficient remnant liver function? Who wants it?
I'll respond to that. That's a difficult question, and the reason is that other members of the immunodiacetic acid family have different hepatic extraction fractions. We selected mebrofenin because this has the most, the highest liver extraction and the least renal clearance. When you use other radiopharmaceuticals, the normal values will not apply. This is a problem. And if you will use other radiopharmaceuticals, you actually should make your own normal values. And this is quite a task because you need large numbers of patients to get these values. So I really would recommend to use mebrofenin because this has a 99.5% hepatic clearance. And for instance, agents like Yodida will have something about 70–75%. So this is really, really important because you want to look at hepatic clearance and you don't want to look at renal clearance. And this affects your normal values. So be very careful with this.
Thank you for your answer. Okay, next question is from Robin Denise. Have there been attempts with dynamic SPECT for the entire acquisition? Whoa, exciting stuff.
Yes, there have been some attempts, and this actually could work. We performed some tests together with a group from Sydney, and actually you can make a SPECT in about 10 seconds. You should do this with continuous SPECT, a really fast SPECT, and then you have the immediate combination of your uptake and your three-dimensional volumes. We're not at the validation state of this, and the problem is a little bit at this moment with ethical committees who do not like radiation very much, and you need healthy volunteers for this, or patients who need an extra scan because you still need the current technology for their clinical evaluation. But technically, it's feasible, but this will need some more work.
Interesting, thank you.
We, out of interest, we have a Veriton 12-head SPECT only system, which in theory would enable us to go to 5-second SPECT, but we haven't yet. We've actually, the software to do that was just installed today, so we're looking forward to exploring that.
Sounds good. I'll look out for the presentation.
We should collaborate on this.
The next question is from Dr. Manoj Gupta. Professor Bennink, nice to see you and great listening to you again. I found measuring posterior segments 6 and 7 is the most difficult. Any tips for this?
Measuring 6 and 7 on planar scintigraphy is impossible. You really need SPECT CT to calculate the fractional function of these segments. These are actually not that difficult to delineate on your SPECT CT scan and bring the fractional function back to your uptake rate measured on dynamic scintigraphy. So it is feasible, but you need your three-dimensional imaging for this.
Thank you. The next question is from Aram Parthapan. Aram asks, the injected activity in Roel's papers is 200 megabecs, but the RSAC limit, which is the British limit for how much you can inject into people, is 150 megabecs. Is it okay to use this technique with 150 megabecs?
But it works for us, Aaron.
Yeah. Good stuff. Thanks, Michael.
Yes, generally it should work, because your like Michael showed, the uptake is so intense in the liver that your flux is high, and if you make the SPECT in all about 6 to 10 minutes, then it works. If you go to very fast SPECT, then you should perhaps look at it again, or adjust your collimator. But 150 megabecquerels should be okay.
Thank you. Aram has a second question. He asks, are the bile ducts removed from the volume to performing segmentation of the liver? So what I showed you just then, yes, we're able to use the masking volume to do that. Then he goes on to ask, does Hermes have any automated segmentation tools for the liver? That's something that we are working on. But hopefully, as you saw from well, Michael's presentation and from what I showed, it's not actually too time consuming to do that yourself. But we are looking into it, yes. But we don't have anything right now, is what I would say.
I mean, Helena, it's using the SPECT count density to outline the liver is usually okay, but sometimes you will find that there are significant well, there are significant intrusions into the liver where you do want to go to the anatomy instead.
Right.
That's my experience.
Okay, thank you. This question is from Daniel Lalonde. Daniel asks, Michael will not name the name of the mathematical procedure to obtain the extraction fraction from the uptake curve. I am curious, can you name it? Can you point to something to read about it afterwards?
Well, it's just a Patlack. So it's the Rutland-Patlack plot. But the reason I didn't describe it that way is because anybody that looks up the Rutland-Patlack plot will find that I've actually scaled the wrong axis. So for didactic reasons, I decided it's easier to visualize the scale of the time axis, whereas the Rutland-Patlack scales the other axis. But it's the same thing.
Thank you. We'll have hours of fun reading about Rutland-Patlack, Daniel. Okay, now we have a question from Gemma Roberts. Hi, Gemma. So Gemma says, hi, Michael. Thanks for your really clear overview. So do you use your own analysis of uptake rate and not the Hermes package method, which is what I showed at the end, with the 150 and 350 second data points? So I guess the answer to that is yes, you use a Patlack method.
That is true, but the Hermes software only uses those data points. Do you use those data points on the? I didn't think you did use those data points actually. Yeah.
We use it for the blood curve, I believe. Yeah,
and well, let me put you straight. We don't use the Patlack method. I've implemented it, and I have stood it alongside the Hermes software, and I assumed you'd implemented it too because they always agree.
Okay.
So I can't see what goes into your software.
Great.
I can help on this. When we were putting this hybrid viewer program together, we did extensive validation, and the Hermes program follows exactly the Ekman protocol. So it uses the data points 150 and 350. But as Patlack, well, it studies the same dynamic, so it's very well as you get similar results. But I can confirm that we use the data points and that actually the uptake rate between these data points is calculated.
Okay, well, there's a surprising concord then with the Patlack plot, because they're as near as damn it they always come out the same.
Good news. Thank you. Okay, we are running slightly over time, but I hope everybody is okay to stay a little longer. We still have more questions from a clearly very curious audience, which is great. Okay, another question from Daniel Lalonde. Michael, extraction curves will obviously contain more noise than the idealized curves shown here. What is the error margin on your calculated extraction fraction and absolute liver function parameter?
Yeah, I mean, that's a difficult one to answer. Actually, it's not really the noise that's the problem, and I suspect actually there's likely to be more noise on the picking of just the 2 points, as Roel has just described the Hermes software does. But in terms of reproducibility, I think we're down at something like plus or minus 0.1% per minute, something of that order, maybe a tiny tad more. So it's pretty reproducible.
Great, thank you. Another question from Aram. Aram asks, do you perform the scan in all patients undergoing liver resection or only those in the high risk category?
I can answer that. I think there are units which are doing it routinely. We have been doing it for high risk patients, and we determine them to be high risk, or we based on their underlying pathology. If we're doing cirrhotic resections, somebody had 8 months of chemotherapy for colorectal liver mets, or you look at the scan, you have some signs of portal hypertension, larger spleen, post-chemotherapy, indicating sinusoidal obstruction. And we are pretty much doing for everybody requiring extended hepatectomy, extended right, completely up to segment, including segment 4. We're not doing for a straightforward right or left. I don't know what Roel's practice is at Amsterdam.
Well, you're right that it's most indicated for major liver surgery. We practically include every patient at this time point, mainly because they all participate in studies. But if you look in outcome, and I get the question in a patient with a future remnant liver of segments 5 to 8, generally I can predict the outcome. But not always, and particularly not in patients with Klatskin tumors. They have more reasons of hepatic comorbidity, mostly due to the obstruction they had. So I agree with your answer, but we include more patients mainly for study reasons.
And just to add to the previous question, whether we could get 6-7 volumetry, once we get the total liver volume outlined, we have done various combinations. We've done right, left, you do 6-7, or you can do 5-8 as well. You do 5, 6, 7, 8, and do 6-7, and exclude 6-7 to get 5-8. So the software works perfectly to get any kind of liver resection you mentioned. Yeah.
Thank you. Okay, a question from Anthony Ciarello, I'm sorry again. In Canada, there is a shortage of mebufotenin, so we are using desofenin. Unfortunately, desofenin has a greater proportion of renal excretion, which affects uptake calculation. Does anyone have experience assessing future liver remnant function using desofenin? Any known corrective factors that can be used with it?
Well, this is a bit the same as the previous question on different agents. Shortage of mebufotenin is really a problem, and manufacturers sometimes have difficulties delivering, and we should really put energy into this to have larger quantities of mebufotenin available. Other agents have very different dynamics and different hepatic clearance, so be careful with this. Normal values do not apply.
Thank you. Another question from the same person. In your experience, what proportion of patients with a calculated future liver remnant function of greater than 2.7% have complications post-op? Any mortality?
I can. Sorry, go ahead, Roel. Go ahead.
Well, you can add on my command. Generally, we see reduction. It's not exclusively. Patients can have post-operative problems due to a number of reasons, but primarily failure in patients who have sufficient function on your preoperative scan is not very common, but sometimes it does occur.
Yeah, so if I can add to that, I agree with that comment entirely. And for me as a surgeon, the PHLF liver failure is not purely dependent on the volume only. You do a venous reconstruction, portal venous reconstruction, and have a complication from that, or you have bad septic complications, commonly bile leak or intra-abdominal collections, or a bad chest infection. They would put additional stress and they can increase the risk of PHLF, which we are not taking into account when we do the functional assessment preoperatively. That's one thing. And the second thing, I'm actually interested to know Roel's comments about when we have an occasional patient who we think in the 100 patients we did, we had a couple of them with less than 2.7, but they seem to have perfectly normal liver functions. What would you do in that case? Would you definitely put them as a high risk and recommend two-stage resection, or would you go ahead with the surgical resection in your unit?
That's a good question, and I believe this depends largely on the type of patient you see. For instance, if you have a relatively younger patient with colorectal liver metastases, who will have generally a normal liver without high chance of hepatic comorbidity, this patient will probably have enough reserve capacity when you have, for instance, a preoperative value of 2.5 or 2.4% per minute per square meter. On the other side, if you have a somewhat older patient with HCC or cholangiocarcinoma, or a patient with a Klatskin tumor, those patients have much higher risk of hepatic comorbidity, and probably you would like to have a little more than 2.7% per minute per square meter to be at ease. So it depends a little bit on the type of patient, and what is interesting for the coming years is probably also to look at hepatic functional reserve capacity, because you can imagine that you have one patient who has his function at 2.7% per minute per square meter, but this is his absolute maximum capacity. But another patient might have his Hebis scan at rest, and we measure 2.7. But if you would challenge this patient before your scintigraphy, for instance, by giving him a fatty meal, you could see that this function would increase to 3.3 or 3.5% per minute per square meter. So this liver can do more, and this is something which is interesting to look into, if we can do a sort of liver functional challenge test to see if this liver can step up, because patients who have a liver which can step up might have much better outcome than patients who are already at maximum capacity before they start the operation.
That's an intriguing thought, Roel. Mike, we should talk to Roel about this again.
Yeah.
Thank you. There are still more questions. It's so great to have all the expertise here and keep on leveling these questions. We are getting towards the end of the questions, but we still have more. Okay, so this is from Larissa Van Golen, sorry. Thank you for these nice talks. I have a question for Roel Bennink. Number one, what is the patient preparation for the scan? E.g., do you stop opioids? Question two from Larissa is, and why is liver function corrected for body surface area? Did you ever see problems in small patients?
Hi, Larissa, and nice questions. First is we do not generally, the only preparation we ask for is fasting for a few hours. This is also questionable because the liver might work a little harder if you have had a meal. But for standardization purposes, we ask patients to come fasting. Opioids is something different because opioids might give a contraction of your sphincter of Oddi and delay your biliary excretion. So generally, we are not in favor of this, and we ask them to stop if it's possible. The least interference of medications, and for standardization reasons, we have them fasting. Can you please repeat shortly the second question for me, Helena?
Yeah, certainly. Thank you. So why is liver function corrected for body surface area?
Okay.
Did you ever see problems in small patients?
You can imagine that somebody who measures 1.70 meters and weighs 50 kilos has different metabolic needs than somebody who is 2 meters and weighs 120 kilos. So this is the main reason that we came up with the idea for normalization, basically because for other treatments like chemotherapy, normalization is also done. We don't have that much experience in infants or very small patients, but I've been working together, and this is not a very popular expression right now, but I've been working together with a Russian group who has done a lot of resection in infants, and there you see that normalization is mandatory because you'll get totally different results if you do your calculations on very small children. So I think normalization is logical.
Thank you. Interesting. We have a question now from Nobi Varghese. Do we need to do a tri-phase CT scan?
Well, it's not necessary, but you can do it. We perform low-dose CT because all these patients already have or a venous phase CT or a 4-phase CT, which is quite recent, so we don't need to do that. Hermes software even enables you to import a 4-phase CT scan or the venous or the arterial phase CT scan if you want to, and you can do the co-registration. So you have all options.
Perfect, thank you. A question now from Subhash Karuka. I used the MIPAV or MIPAV program to calculate remnant liver function. How is it different? I don't know if anyone's familiar with this program. I've heard of it. MIPAV.
I've heard of it, but I'm afraid I haven't used it, so I can't comment on its use in this context.
So Subhash, we don't know that one. Okay, another question from Dirk. Similar to previous stuff, which radiopharmaceutical is preferable to be used if mebufotenin is not available? I guess we don't really have a decided
that's not really an alternative, but well, this is particularly for Europe. Mebufotenin is made by different vendors, and if you search around, you look around, you can find mebufotenin, for instance, from Polatom in Poland. It's made by GE Pharmaceuticals, and there are some other vendors. So if you search, most of the times you will find it if there's shortage from your normal supplier.
A question from Nobi Varghese. How is the insurance cover the SPECT CT scan for future liver remnant calculation? I guess that's a question from the States. I have no idea on that one.
in some countries it's reimbursed, in others it isn't. But then you have to make your calculation and talk with your surgeons or your hospital, because one day a patient 1 day on intensive care is far more expensive than performing a scan. So it's sometimes it can be an easy calculations and make your business case.
That's a really good point. Another question from Larissa. Larissa asks, is total segmentation in Hermes possible? Brackets, function for all separate segments. We don't have a particular workflow for that. Technically, it would be possible. It would be a manual process, and you would have to go through and outline every segment. Yeah, so technically possible, but maybe not really a practicality. A question from Anthony Chiarallo. Immediately following liver deprivation, how does this impact the total liver uptake rate? Does it diminish in proportion to the targeted liver volume?
It depends a little bit on how you look into this. For instance, if you do a portal deprivation of segments 5 to 8, and you would do the scan a few days later or a week later, your total liver uptake generally would be diminished, because the functional increase of your future remnants or the non-deprived segments takes time before they get to the level. So it depends a little bit on how much deprivation has been done and what the timing is after deprivation when you perform your scan. So in general, function will decrease a little bit immediate after deprivation, but due to hypertrophy and increase in function later on, it will be there will be a compensation.
Thank you. Okay, getting towards the end, we have a comment here from Sibi Uman. He says, in our center in India, we perform fast SPECT CT of 6 minutes SPECT followed by CT. It does a good job for fast SPECT, even up to 8 millicurie for count rate or flux will work. Okay, thank you. Some feedback saying that it's an excellent webinar, very informative. Thanks very much for that. Vivian Ma asks how to determine the cutoff value for the patient. Do we need to exclude the intrahepatic biliary activity? Yes, so I showed in the Hermes application that you can mask that out to get the true functional representation of the different areas of the liver and how they contribute to the uptake. And the cutoff value in Roel's presentation is 2.7%, and you can read up on that in his publications. What have we got? So I'm just trying to scroll to the end of the list. A question again from Sibi. Fasting for how long? Won't fasting impair mebufotenin uptake? Did we talk about fasting?
Well, generally, fasting will result in a resting state of the liver. And we generally ask 4 hours. We did an interesting study, and we call it the chocolate study. We asked some healthy volunteers in different age categories to come twice, both times fasting, but on the second scan, we gave those volunteers 200 milliliters of full milk, full chocolate milk, half an hour before injecting the radiopharmaceutical. You will see after a fatty meal that cholecystokinin is released, and this will enhance your liver function, and you will see that liver function increases. We did this to have a first look at functional reserve capacity, but liver function changes if patients eat. and particularly fatty meals. So that's the reason why we asked them to come fasted, to have to be able to use the normal values in the same perspective. So it does alter, and it's just important to know what you're doing. And at this stage, we prefer to have them fasting for normalization reasons.
Thank you. Let's call it here, shall we? We're now 10 minutes over the official end time. Thank you so much, everybody, and especially to our panelists for sharing their expertise and staying over to answer all these questions. The session is recorded, so if you want to access it, then there will be a link that you can use to watch it again if you'd like. If there are still questions that you would like answered, feel free to email Hermes and we will pass them on to the relevant person. So thank you again, and good night, everybody.
Thank you.